looking at interventional or experimental study designs. The branch of epidemiological research where we don't just observe, we give interventions to the study participants who could be patients. So I'll start with giving an overview of epidemiological study designs, and we had looked at this in the previous session. So we said they are broadly categorized into two groups. So either observational studies, where we don't interfere, we don't give an intervention, we just watch and observe characteristics of study participants. And observational studies can either be population-based or individual-based. And then individual-based can further be described as being descriptive. So we just document characteristics of patients, and this can include case reports, case series, or descriptive cross-sectional studies. Or they can be analytical, where we try and describe associations between various variables. And we said examples of this are cohort studies, case control studies, or analytical cross-sectional studies. Today, our focus will be on experimental or interventional studies, where the researcher usually gives an intervention to a group and then observes to see whether there's an effect that occurs after that intervention and tries to describe it. So experimental studies can be broadly classified as randomized controlled trials or non-randomized. Now we will dive into each of these and understand what they mean. So we start with randomized controlled trials. What are they? So the randomized control trials are an interventional or experimental type of study design, and they're usually considered to be gold standard in evaluating the effectiveness and safety of interventions. And in subsequent slides, we'll try and see why they're considered the gold standard. So they have two key features, randomization, and they're also controlled. So randomization or random allocation is the process where study participants are usually assigned into different intervention groups purely by chance using a random method. And this is to ensure that each participant has an equal probability of receiving any treatment. And then they're also done in a controlled environment. They're also done in a controlled environment, which means that the trial is conducted under planned, standardized, and closely monitored conditions, so that the only major difference between the groups is the intervention that is being tested. So basically this randomization and the controlled environment just helps to minimize bias and also balance both known and unknown confounding factors across groups, thereby increasing the validity of the study. So to help us understand RCTs better, I had earlier shared a case that was published in the New England Journal of Medicine. I hope you've all had a chance to briefly go through it. But if you haven't, I'm linking the study to the chat. You can quickly have a look at it. So it was titled Early Tirofiban Infusion After Intravenous Thrombolysis for a Stroke. Oh, for stroke, sorry. Yeah, so this was the background. They're basically saying intravenous thrombolysis is the standard treatment for acute ischemic stroke, presenting within 4.5 hours of onset. However, after this, there may be vascular reocclusion. Yeah, so they're trying to see if tirofiban, a platelet glycoprotein receptor antagonist, reduces this risk of vascular reocclusion, and it has been shown to do that in experimental models. So they now want to check it in humans. So there's a brief description of that. Now, having gone through it, I would like us to, maybe you can just answer in the chat, what type of an RCT was this study? So what type of an RCT is this? Or answer in the Q&A. Anyone? What type of an RCT do you think this is? So even looking at this abstract, they've basically tried to tell us what type it is. So it is a double-blind, randomized, it's also placebo-controlled trial. Okay, so that's good. So it's double-blind, yeah, RCT. What are some features of an RCT that you are able to pick as you read through this study? Anyone? Any features of an RCT that you're able to pick as you read through this study? Okay, good. So there was blinding, and in this case, it was double blinding. The patients were also randomly allocated to the group, so there was randomization. Anything else? Yeah, so for the control specifically was a placebo, so it was a placebo-controlled RCT. Yes, good. So those are some of the features of an RCT, and we'll look at some more in subsequent slides. Okay, so using this case again, we'll try fill in the PICOS framework that was used for this case. So PICOS, the P stands for population. So in this case, the population is either the patient or the problem that was being assessed. So based on the study, what is the population? So the study population, as correctly pointed out, was patients who experienced ischemic non-cardioembolic stroke and who had received IV thrombolysis for it, and they had presented less than 4.5 hours within stroke onset. Yeah, good. What was the intervention or the exposure? Sorry. Okay, sorry for that. So the exposure in this case was 24-hour intravenous infusion of tirofiban. Good. Which was the comparison group? Or what are we comparing the intervention with? Yeah, so a placebo. Good. And what was the primary outcome? What is the primary outcome? Yeah, so an excellent functional outcome based on the modified ranking scale at 90 days. Yeah, so I'm seeing someone was asking that I briefly show the study. So this is the title. This was, sorry, the title and part of the abstract. Okay, so thanks so much for your responses. We can now proceed. So randomized controlled trials are considered the gold standard because of number one, the fact that they minimize influence by other factors, which could be confounding variables or just various types of bias. And as alluded to earlier, this is mostly because of the way they are structured. So number one is by randomization. And we said randomization is the process of assigning study participants to different intervention groups purely by chance using a random method. And this is to ensure that each participant has an equal probability of receiving either the intervention or the placebo, for example. And then there's also blinding. So blinding means keeping certain people involved in the study. So blinding means keeping certain people involved in the study unaware of treatment assignments to reduce bias. And it can either be single blinding, double blinding, or triple blinding. And we'll look at that in subsequent slides. Yeah, so blinding basically just helps to reduce bias so that number one, participants or staff don't change behavior based on their knowledge of the treatment, or when someone is assessing the outcome of the study, they're doing so in an unbiased manner. And then it also makes the study more credible because results are less likely to be influenced by placebo effects or observer expectations. And then there's also allocation concealment, which is basically the process of hiding the upcoming group assignment from those enrolling participants. So after randomization has been done, you conceal which patient goes to which group. So the person allocating groups does not know what patient goes to which group. So this prevents selection bias where recruiters may either consciously or unconsciously assign certain patients to one group. Yeah, so all this factors that are aimed at reducing confounders and bias then allow for evaluation of a causal effect. And now this contributes to why RCTs are considered the gold standard research designs. So we've talked about randomization. So how would you randomize patients in a trial? So there are various ways. Number one, you can do simple random sampling. So sampling just refers to how patients are chosen and assigned to groups to ensure fairness and reduce bias. So after defining the eligibility criteria, randomization methods are then used to allocate participants. So you can do simple random sampling where every eligible participant has an equal chance of being assigned to any group. So this can be done using a random number generator. So you give random numbers and then you pick specific numbers to go into either the intervention group or the control group. So it's advantageous in that it's simple and unbiased, but then it may result in unequal group sizes or imbalance in important characteristics, especially in small samples. So then we can consider block randomization, otherwise known as blocking. So in blocking, participants are usually grouped into blocks based on some similar characteristics that are shared. And then from those blocks now, we pick a random number of people to go into the intervention group or the control group. So the advantages of blocking are that it prevents large imbalances in group sizes over time. And then it also now helps prevent like a mismatch of important characteristics among the patient groups. Then we can also do stratified random sampling. So participants are usually first divided into strata. So from this example, you can see here they're stratified by sex. So we have males and females. And then after that, they're stratified by age. So into younger males, younger females, older females. And then from each group, we now randomly, now using just a random method, we pick random members from this strata and categorize them into either the intervention or the control group. Yes, so that's how randomization can be done. And then we've said the other key component of RCTs is blinding. So, and as we said, blinding is where one party does, one or more parties do not know which treatment they are receiving. So there are various types of blinding. We can have a single blind study where only one party, usually the participants, do not know what treatment they're receiving. And this is mostly to reduce the placebo effects and participant expectation bias, which may skew their findings. So we usually use single blinding when it's not feasible to blind the investigator. So for example, when you're comparing surgical techniques, where the surgeons must know which procedure they perform. So there we only blind participants. We can also have double blinding. So in double blinding, both the participants and the researchers, sometimes including those delivering the intervention, do not know who is in which group and therefore who's receiving the intervention and who's receiving the control. So double blinding reduces bias from both participant expectations and researcher influence. And it is usually considered the gold standard in drug and vaccine trials whenever it's possible to blind both the participants and the researchers. Then we can also have triple blinding. So here, participants, researchers, and those analyzing the data are all blinded to group assignments. So this eliminates bias even at analysis stage. And it's used in like high stakes trials where results may influence major policy or commercial decisions. And therefore we want to try to be as objective as we can. Then we've also talked about control groups in RCTs. So we can have two types of control groups. It can be active control, where we're using like a drug or a surgery that's the standard of care, and we are comparing it with a new intervention to see whether the new intervention is more efficacious or not. We can also have placebo controls. So this just basically helps separate the real effect of a treatment from psychological effects. Now, when using placebos, there are a lot of ethical considerations that we have to have in mind. So placebos are only acceptable when there's no proven treatment or withholding treatment isn't harmful. And this is especially tricky when it comes to sham surgeries because they carry an extra risk and they're invasive, and so they need strong ethical justification. Yeah, so we have to assess for risks and harm and compare them with potential benefits of not giving a certain group of patients the active drug and giving them placebos instead. And then we also need to consider the scientific validity. So placebos improve study accuracy, but just as I said, we must balance that with study ethics. So in some cases, active controls are used instead. And then participants must also know about the possibility of being given a placebo or a sham and the risks involved with that. And they should be told of their right to withdraw freely at any point in the study. So the other feature of RCTs is that they have clear and meaningful outcomes. So usually we have a primary outcome that is the main endpoint of the trial, or rather the main endpoint that the trial is designed to assess. It needs to be clinically meaningful, objectively measurable, and it is usually chosen before the trial begins. And now the sample size required for this study is calculated based on the primary outcome. Then we also usually have secondary outcomes that just provide supportive evidence or assess the safety, satisfaction, or process metrics in the study. Okay, then now based on those key features of randomized control trials, the randomization, allocation concealment, the use of controls, the blinding, and the clarity of the primary and secondary outcomes, what forms of bias, therefore, are these RCTs trying to reduce? So number one, we have selection bias. Selection bias occurs when patient characteristics differ between groups in ways that could affect outcomes. So how do we minimize selection bias? By randomization. So just randomly assigning participants to either intervention or control group so that you do not have much baseline differences in terms of any confounding variables. And then also through allocation concealment to ensure that the person enrolling participants cannot predict the next assignment, so they cannot manipulate assignment to groups. Then there's also performance bias. So performance bias happens when differences in care other than intervention influence outcomes. So this can be minimized by blinding. So again, either single or double. So, okay, blinding basically minimizes expectancy effects and also differential treatments, especially from like the researchers. Then you can also have detection bias. So, and this can be reduced by standardized outcome assessments and blinding as well. So we risk detection bias when outcome assessors know which group a participant is in. So they may be like biased towards maybe reporting a certain outcome for individuals in the intervention versus those in the control group. So using standardized tools and blind assessors just try to make the outcome assessment as objective as possible. Then we can also have attrition bias. So attrition means just basically people falling off from the study or not adhering to, like maybe the medication that they're supposed to take during the period of the study. So this is reduced by one, robust protocols, so including robust follow-up procedures so that you just minimize loss to follow-up among the study participants, and then also use of intention to treat analysis. So this basically means that all randomized participants who were included in the study at its start, their data will be analyzed in the final analysis, regardless of whether they dropped off the study or they continued throughout. Then there's also reporting bias, where people may be inclined to just selectively report favorable results. And this is reduced by using standardized reporting guidelines, such as CONSORT, to ensure that all outcomes, be they positive, negative, or neutral, are presented. Okay, so we briefly look at CONSORT. Sorry, so CONSORT in full is Consolidated Standards of Reporting Trials, and it is basically a protocol that was developed by a group of researchers to identify problems arising from RCTs, as well as to help in full and clear reporting of results yielded by research, thereby facilitating proper RCT reading and also quality assessment. So it basically just aims at improving transparency and clarity in reporting the results of an RCT, improved reproducibility, also helps in critical appraisal because now we can assess the quality of an RCT. Then it also helps in ensuring that the results are complete. I don't know if you were able to access the CONSORT diagram for the study that we've been using. Or rather, like the entire protocol. Is anyone able to access the protocol for the study? Okay, so I hope you can see my screen. Yeah? Okay. So this was the protocol for the study we've been looking at. So there's the title, Advancing Stroke Safety and Efficacy Through Early Tirofiban Administration After Intravenous Thrombolysis. And then there's the table of contents. Yeah, so I just wanted to show okay, so part of the consult guidelines are that we have a clear synopsis of the study. So this one shows the title, the background, rationale, objectives, like that, inclusion and exclusion criteria, and then the details of the intervention, and then the main study parameters, secondary outcomes, safety outcomes, how sample size was calculated, like that. And then, so after giving the background information, they now show us the consort diagram. So acute ischemic stroke patients presenting less than 4.5 hours after onset. They were meeting the criteria that were outlined above. And then after that, obtaining informed consent, how randomization was done, and the patients divided into two groups, the tirofiban group and the placebo-controlled group, and then what interventions were given until after the procedure, okay, after the whole protocol at 90 days, how the outcomes were assessed. So this is the specific consort diagram for this study. So it's just aimed to help in full and clear reporting of results, and also to facilitate easy reading and assessment of quality of RCTs by other researchers. Okay, so now we briefly look at the phases of RCTs. So they're usually divided into 4 phases, or technically 5. So the first phase is usually the early discovery or preclinical research phase. Yeah, so this is where the idea for a new treatment begins, often from basic science. So just identifying potential targets or compounds. And then now in vitro studies are usually done. So these are experiments that are done in test tubes, petri dishes, or cell cultures to just understand mechanisms, say, of action of a drug and its potential effects. And then in vivo studies are usually done in animal models to see how the compound behaves in a living system. So they cover safety, toxicity, dosing ranges, and most importantly, biologic activity. Now, these phases usually just help decide whether a treatment is safe enough to move to human testing or not. And then to note is that most potential drugs never really make it past this stage. In case a drug makes it past here, then we move to phase 1 of RCTs. So these are usually the first in human trials. They're usually done in a small group of individuals, usually about 10 to 24 healthy volunteers, or sometimes patients, depending on the drug being checked, for example. And they just aim at checking for safety, tolerability, and best dosage range for the drug. After that, we move to phase 2 trials, where we basically assess for efficacy and side effects. And this usually involves fewer than 100 participants with the target condition. And here we look at how well the treatment works and continue safety monitoring as well. Then we now move on to phase 3 trials. So the example we're looking at in this case was a phase 3 trial. So it usually involves hundreds of participants and is aimed at confirming effectiveness, monitoring side effects, and comparing the new drug or the new intervention with standardized treatments. And then after that, the data is usually submitted to regulatory agencies for approval. After approval, then the treatment is usually used in the general population, marketed and used in the general population. And then during this period, we try to detect rare or long-term side effects. And then those will now help us refine usage guidelines for these drugs. Okay. Then finally, we look at the various types of RCTs. So the diagram on the left just shows how we can classify RCTs. So we can classify them based on blinding. So they can be open label RCTs where there's no blinding at all, or they can be single blinded, or they can be double blinded. And I think we've exhaustively discussed this. Then RCTs can also be classified based on control groups. So they can either be parallel RCTs. So in parallel RCTs, there's usually two groups, one that receives the intervention and another that receives the placebo or control. Yeah, so the placebo or the drug that is currently used for that condition. And then after the period of the study, we now look at the outcomes and see whether the intervention is better or same or not really better than the active drug we are comparing or with the placebo. And then we can have a crossover RCT. So in a crossover RCT, we have a group of patients. We give them, say, the intervention drug for a period of time. So say 4 weeks. And then after 4 weeks, there's a brief period, say 1 week, called the washout period, that is meant to just allow the effects of the intervention of the drug wear off. And then after that washout period, we now either give them the placebo or the active compound. And then we now compare the response either with intervention 1 versus intervention 2. So it's like we're basically just using the same participants as their control. Yeah, and now compared to a parallel RCT, it requires fewer participants. And then we can also have a factorial RCT. So the simple one is the 2x2 one, which I will use to illustrate. So say we have intervention A, and then we have intervention B. And there's also an option of combining both intervention A and B. So basically we'll have like 3 intervention groups. So either A alone, B alone, or both A and B. And then the control will have neither A and B. So now we'll be comparing those who are receiving either only A to the control, those who are receiving B only to the control, those who are receiving A and B only to the control. So that's how factorial RCT works. So the advantage of this is that it helps not only compare a single intervention, but also like a combination of maybe 2 interventions that could work together for a more efficacious response. Then RCTs can also be designed or interpreted based on either the superiority of the intervention over control. So we can have superiority RCTs whose goal is to show that a new treatment is better than the current standard or a placebo. So for example, testing if a new painkiller reduces pain more effectively than the standard drug. Then you could also have equivalence RCTs. So these are meant to show that two treatments have no meaningful difference in effect. So they're essentially the same within a defined margin. Yeah, so for example, a generic drug working equally as well as a branded drug. Then you can also have non-inferiority RCTs. So they show that a new treatment is not worse than the standard by more than a pre-specified margin. So useful when the new treatment may have other benefits of, for example, fewer side effects or lower costs. But they're just as efficacious as the current treatment that is being used. So in summary, what are the features of a good RCT? One, a clear question that is defined by a clear PICO framework, as we saw. Robust randomization, appropriate controls, feasible and ethical blinding, pre-specified outcomes, and then transparent reporting. Yeah, so if an RCT like ticks all or most of these boxes, then it is considered a good quality RCT. Okay, so that's it for the randomized controlled trials. I think we can take a short break, then come back, finish with non-randomized interventional studies. Okay, so I think we can continue now. Shift gears to non-randomized interventional studies. So in non-randomized interventional studies, investigators actively apply an intervention. So it could be a drug, a surgical procedure, or a public health program. However, unlike randomized controlled trials, here there's no random assignment of participants to different groups. Instead, group allocation is determined by other methods or other factors. So for example, patient preference, physician decision, availability of the intervention, or already pre-existing groups. So there are various types of non-randomized interventional studies. So we'll first look at field trials. So field trials involve evaluation of whether a method, which is usually mostly a public health program, reduces risk of developing disease among those that are free from a condition. We look at an example. So it is usually done among a group of people. So it could be a household, a cluster of households, or a school, for example. There's usually higher realism because the study participants are in the natural or usual environment. So the results that you get are likely a clear picture of what happens in reality. However, there's a high potential of bias because there could be like so many confounding factors. So we'll look at an example to cement this better. So say researchers want to test a new malaria vaccine in healthy children before large-scale use. So there are 2 rural districts with similar malaria risk. And then we enroll children who are disease-free at baseline and then randomly assign to either receive the new vaccine or the placebo. So the trial is conducted just within the community rather than a hospital. And then the patients are followed for 2 malaria transmission seasons to compare infection rates. So it's non-randomly assigned. So maybe based on if you're getting the nets, for example, from a dispensary, so the district or the group of people that's closer to that dispensary will be given the nets. The ones that are far from that dispensary won't be given the net. So it's non-random. It's non-random assignment to either receive the new vaccine or the placebo. And then after 2 malaria transmission seasons, we now compare the infection rates. So now that would be a field trial. Community trials, on the other hand, are almost similar, but here we now get an entire community instead of just a small group within the community. And then the intervention is implemented at population level to evaluate its effectiveness in improving health outcomes. So just like field trials, it is good for real-world public health evaluation. However, there's risk of contamination or spillover of intervention to control community. So like so say in a rural district, health officials launch a clean water and hygiene program to reduce diarrheal illnesses. Then chlorination systems are installed and hygiene education sessions are held in 5 villages located closest to the district headquarters because of ease of regular monitoring. And then the remaining 5 distant villages continue with their usual water sources and practices. And then after 12 months, researchers compare their real disease rates between the 2 groups. So again here, the intervention villages are selected for logistical convenience rather than random allocation. And then the differences in like occurrence of diarrheal illness are then compared between the two groups. So there's an intervention, which is the chlorination systems and health education sessions, but then there's no random allocation. It's based on predetermined like factors in each case, the logistical convenience. Then the third type of non-randomized interventional trials are quasi-experimental studies. So these are usually, they can either be interventional or pseudo-experimental studies. So pseudo in that they may mimic the structure of a true experiment. So having both the intervention and the comparison, but lack random allocation of groups. And then, yeah, so there are basically two forms where the researcher actively applies the intervention. And there's another form, especially the one that now gives rise to this quasi-experimental denotation, is where the researcher just observes a naturally occurring intervention without directly controlling it. An extra pertussis booster for children. Similar size and demographics continues with the old schedule due to supply delays. So the research is designed in such a way that the researchers will compare pertussis under 5s in the next year, both in counties A and counties. And the intervention wasn't really assigned by the researchers themselves. It just so the intervention is not really being given by the researchers, but something that just happened to occur at around the same occur shortly, and then they decided to now research. So it introduces a bias in the sense that counties may differ in healthcare access, population mobility, or reporting accuracy, which could now influence results. So it may, like drawing, you may not confidently say that incidence of pertussis reduced in county A and not in county B because of maybe adherence to the new vaccination guidelines, because county B was different from county A in terms of healthcare access and maybe other potential ways like reporting accuracy, population mobility, and this could now skew the results. Yeah, so that's basically it for non-interventional studies. We will now briefly look at internal and external validity. So internal validity is the degree to which observed effects are truly due to the intervention and not to bias, confounding, or chance. So like when we do interventional research, how sure are we that the effects that you're getting are due to the intervention that you gave, be it the drug, a public health program, or a surgical procedure, and not really due to bias, confounding, or just chance. So studies with high internal validity usually have like a strong causal inference, like we're almost sure the effect is actually due to the intervention. So I'll share this case. So researchers conduct a before and after study in a regional hospital surgical ward to test a new wound care protocol aimed at reducing post-op infections. The infection rates are measured for 3 months before and 3 months after the protocol is implemented. During the study period, staffing changes occurs, including the arrival of 2 senior nurses with advanced infection control training. After the study, the researchers report a significant drop in infection rates after the wound care protocol is introduced. So based on this case, how confident are we that the protocol itself caused the drop in the intervention rates? And what are some of the factors that you think might weaken that conclusion? So maybe you can type it in the chat. What factors do you think might weaken the conclusion that the introduction of the new wound care protocol is what caused a significant drop in infection rates in this surgical ward? So the protocol was not shared. We're just saying it's a new wound care protocol that's aimed at reducing post-op infections. So it's just a hypothetical case. It wasn't really shared per se. Yeah, so the staffing changes, especially the fact that the 2 senior nurses had advanced in infection control training serves as a very big confounding factors, because now we could attribute the drop in infection rates to maybe like the staff with more experience in infection control. So such a confounding variable then poses a very strong threat to the internal validity of the study. Okay, good. Then external validity, on the other hand, is the extent to which results of a study can be generalized or applied to populations, settings, times, and conditions beyond the specific circumstances of the original study. So it basically tries to answer the question, can the findings from a study be trusted to hold true in other groups, places, or situations outside of a particular study setting? So for this, again, we'll consider a case. So a team develops a mobile app lifestyle program to improve blood sugar control in people with prediabetes. The trial recruits 500 participants, all from urban areas, all university educated and under the age of 50. The program shows significant improvements in HbA1c after 6 months. The authors recommend rolling it out nationally to all adults with prediabetes. So based on this case, can we assume that the results will apply to the entire national population? And what changes in study design could make that assumption more reliable? So number one, are we confident that the results here can actually be generalized to the whole population? Okay, so they cannot really be generalizable. So number one, because they were only done in from urban areas, so we might need to include people from rural settings, also include people from different age groups, not only under 50. And then, yeah, so also include people who are not university educated. Yeah, so those are some of the like threats to the external validity of this study that make it impossible to roll it the way it is to the entire national population. Good. So in summary, internal validity basically just means is about whether the observed effect in a study is really caused by the intervention or just another confounding variable. So there are various threats to internal validity of a study. So number one is selection bias. So this is where there are systematic differences between groups at baseline that can influence the outcome. So for example, in a hypertension drug trial, if only younger, healthier patients are assigned to the treatment group and the older patients to the control group, results may be skewed. So how do we minimize this? We randomly assign participants to group and maybe use stratification to balance key characteristics. Also try to ensure allocation concealment in RCTs, for example. Then another threat is history effect, where external events occurring during the study could influence the outcome independently of the intervention. So for example, in a smoking cessation study, a nationwide tobacco tax is introduced midway. So because of the tax, now there's reduced smoking in both groups. So that could skew our findings. So how do we reduce that? We use control groups experiencing the same events and also try not to use very long study durations to reduce exposure to external changes. And then there's also maturation as a threat to internal validity, where there are natural changes in participants over time that could affect the outcome. So for example, in a 12-month physical growth study in children, height increases may occur simply due to aging and maybe not due to the intervention. So again, we minimize this by using control groups, trying to keep the study duration appropriate, not too long, as well as adjust for expected natural changes. Then there's also the testing effect. So participants' performance changes simply because they've been tested before and become familiar with the assessment. So maybe say in education, students improve on a second math test just because they remember the test format from before. So we can use alternate test forms, space out assessments, avoid overly repetitive measures. There's also instrumentation changes. So maybe changes in tools, observers, or methods during the study that could influence the results. So maybe switching from one brand of a blood pressure monitor to another midway through a trial, leading to slightly different readings. So how do we minimize this? We use consistent instrumentation and measurement, consistent instruments and measurement protocols, as well as train assessors and also try to calibrate equipment regularly. And finally, we could have attrition or regression to the mean. So attrition is loss of participants over time, which can result in bias if dropouts differ significantly from those who remain. And then regression to the mean occurs when extreme values tend to move closer to the average on subsequent measurements. So we can reduce this by minimizing dropouts with follow-up reminders and incentives, using intention to cheat analysis. Yeah. Then external validity We said, can the study results be generalized to other populations, settings, or times? So there are various threats to this, including number one, using an unrepresentative sample. So where study participants differ significantly from the population to which the results will be applied. So for example, testing a malaria vaccine only in the young, healthy adult males when it is intended to be used for children. So how do we minimize this? We recruit a sample reflecting the target population demographics as well as characteristics. And then another threat is unrealistic study settings. So conducting the study in highly controlled environments that do not reflect real world conditions. So for example, perfect medication adherence in a hospital setting, which would be otherwise unrealistic in community settings. So we minimize this by trying to conduct studies in naturalistic settings that simulate real-world conditions during trials. Then there's also the time-specific effects, where findings that are valid only at a certain time due to seasonal, social, or economic conditions. So for example, evaluating ice cream sales during like hot conditions and assuming that there'll be the same demand for ice cream all year round. Yeah, so how can we minimize this? Replicating the studies in different seasons or times, or trying to follow up over long periods. And then finally, there can be cultural or context differences. So this limits generalizability of results to other contexts. So for example, a diet intervention based on foods common in Japan, for example, which may not really work in Kenya, where those foods are unavailable or unfamiliar to people. Yeah, so how do we minimize this? We try to adapt interventions to local contexts and then test in multiple cultural settings and clearly describe the original study context. Yeah, so that's it about study validity and the common threats and possible ways to overcome those threats to study validity. Yeah, so thank you for your attention. I'll now welcome any questions.